I don't see it. Ultrasound, very easy. I'm going to demonstrate the problem. Pattern 1. Do you see the carcinoma here? I don't think so, but it's there. Found by ultrasound. And this is what we call the iceberg phenomenon. Only the nose, the spiculations are sticking out. But it's so easy to pick up with automated breast ultrasound. Mammogram, I don't see it. Ultrasound, very easy. Don't even have to be a doctor. But here is the 3D pathology. You see how much of the cancer is actually hidden in the surrounding fibrosis. Here is another case. Good test for a radiologist. This contour is concave and concave and concave. Is this convex? Yes, it is. Right there. That's where the cancer is. But most of the cancer is hiding under the surface, as you see it here. Can I find it with automated breast ultrasound? With handheld ultrasound? No problem whatsoever. I had a problem here. I don't have a problem here. These are the acinar adenocarcinoma of the breast. Even worse, this one measures 22 millimeters. Any radiologist could pass by it easily. What if we are using ultrasound? No problem at all. Here is the tissue defect. It starts to die in the middle. You can expect rim enhancement on MR, but we are not screening with MR. We should screen with ultrasound. And of course, there is no mammographic abnormality whatsoever, but there is a cancer there, hiding totally in the surrounding tissue. And here is, and surrounding fibrous tissue. And here is her handheld ultrasound and 3D automated. It's going to be very difficult for radiologists to point out this contour change, especially if this mammogram is 1 out of 200 in your screening batch. But the cancer is there. Changing the contour. What would the automated breast ultrasound look like? Like this. And so case after case, I can show you this. Then we arrive at the 20%. Now, this is not for ultrasound. Most of the cancers originating from the major ducts calcify. Calcification is for mammography, unless it's a non-calcified neoduct genesis. And then I would expect that there will be architectural distortion. And there is. And here comes the big troublemaker, 5%. Also known as invasive lobular carcinoma, but let me open your eyes. It has nothing to do with the lobules. It originates from the stem cells of the mesenchyme that transform mesenchymal cells, decide to become epithelial cells through transition, MET. And the result is an enormous amount of fibrous tissue proliferation. Now, that's good for ultrasound, but not for mammography. Here is an 8-centimeter carcinoma. Here is a 10-centimeter carcinoma, and here is a 7-centimeter carcinoma. Any radiologist could pass by it easily. But the architectural distortion is going to be seen on automated breast ultrasound. Just compare this, the mammogram, with the automated breast ultrasound. And you may be very depressed if I'm telling you that every bit of radiopaque density here is carcinoma. Here's the proof. How are you going to find this? Not on the mammogram, not at all. Handheld ultrasound or an automated breast ultrasound. That's why we should really have this method in addition to fulfill digital mammography. Concave contour. No, this is what normal fibrogranular tissue looks like. No, this is carcinoma. It's all carcinoma what you see here. Concave contours, fooling the radiologist. Retracting the whole breast. Yeah, because the whole structure is diseased. Unfortunately, also, this one is stem cell carcinoma. We cannot find it early, and there is no cure against it. Sad story. Yes, we can control 75% of all breast cancers, not 25. These curves show that 30 to 40% of these patients are going to die from breast cancer within 10, 15 years. And in the past 60 years, these curves didn't change at all. Despite the development of breast cancer screening, despite the development of new therapeutic regimens. Sad story, but we have to live with it. So one of the questions was what to look for. I'm going to look for tissue defect and find stellate and circular lesion called acinar adenocarcinoma of the breast. I'm not going to look for calcifications, but I'm going to look for a huge ultrasound finding, the 5%. But the next question is, where? Is there any specific region in the breast where I should look for these? Yes. A woman is standing in front of you. Think about it. 80% of breast cancers are in the upper half, 20% in the lower half, leaving about 1 to 2% for a retroareolar region. But also, 70% of all cancers are in the lateral half, and about 30% in the medial half. Now I know what am I looking for. Now I know where I'm going to look for. Let's do it. I'd like to mention to you a very simple comparison. ABUS is taking 2 millimeter tissue slices. Now, I photographed a children's book, which has 2 millimeters thick pages. That's very comparable to reading ABUS. There are 3 acquisitions per breast. That means that you radiologists have to read 6 books looking for a tissue defect. Let's take the most troublesome, the Biorez D, the pattern 5. Homogeneous, ground glass-like, structureless. What's in it? Wintertime? Springtime? Don't know. Big problem. I don't see parenchymal contour retraction. I don't see bulge out. And I don't want to sign this. I need help. Now, help me. Please. Here's a case. Sad enough. 37. She herself feels a lump. Clinical breast examination. You feel it yourself as a clinical breast examiner. And you see nothing. And you ask for magnification. No mammographic finding. No tumor mass, no calcifications. CC projection. Then you use the 3D automated ultrasound that actually acts like a radar. It penetrates this homogeneous, dense fibrous tissue, and you find a filling defect. I mean, you find a tissue defect. And that actually measures 12 millimeter. I don't believe I felt 12 millimeter. I don't believe the patient felt 12 millimeter. And you know very well, when a woman under 40 feels a lump and it turns out to be a cancer, and it's most of the time multifocal and most of the time very aggressive. Where is the other one? Here. You see the ribs, you see the muscles, and this one makes sense because although this one measures 12 millimeter, the second measures 29 millimeter. Now, that makes no radiologist happy because I missed 12 and a 29 millimeter. Nobody can find it on the map. It's there. It's there on an automated breast ultrasound, on the handheld ultrasound. And if it's multifocal, you can count on it. It already gave metastasis. You prove it. And you do an MR. Yes, there is very extensive enhancement. Nevertheless, it shows both of the cancers. And here is a disappointment. Now we have to do something about this. And that's what we call automated breast ultrasound plus mammogram as screening tool. 2 nodes are metastatic. You shouldn't go on like this. One more case on this virus, a D, 45 years old. She herself felt a lesion. Do you see it? Well, somewhere in this direction. Could this be this one? Give me ultrasound. And it's, of course, very simple to see. Dyes in the middle shows that this is an aggressive, fast-growing carcinoma. Put the needle in. 1 shot is enough. Very aggressive, poorly differentiated carcinoma. Fortunately, unifocal. Here is the proof on MR. High-res MR. Upper outer quadrant. Unfortunately, had a very thin margin. You use ultrasound also on specimen X-ray. Here is the solitary lesion. Fully differentiated. Too large. Should have been picked up earlier. But there is not a chance for mammogram. For the mammogram, find it. Let's take one step back. Pattern 4. Bad enough. You know now what pattern 4 is. It's actually a harmonious pattern. So you have to spend a little bit more time to view it side by side, step by step. You got this information as well. And it doesn't change. It's a high-risk pattern. Actually, if you really want to talk about risk, this is the only pattern that is high risk. Not the 5, not the 1. Unfortunately, BI-RIS does not distinguish this one from the others. Here is one, fortunately, the patient pointed out the thickening here. Yes, it's visible on the mammogram, especially if somebody points out. But it's much easier on 3D automated ultrasound. Now, suddenly you see 2 defects. One of them is gray, the other one is very black. This one, the gray, is multifocal. Put the cursor there, obviously a carcinoma. Let me tell you, if it's very black, then it's very much possibly an air bubble. So this is artifact. But the MR shows that it's much more extensive disease. It's both multifocal and diffuse, which means double trouble. Multifocal AABs and diffuse cancers harm women. And this was developing in a pattern 4. And this was not detected when it was 10 millimeter. Just very quickly, moving towards the end, in order to tease the poor radiologist, one of the breasts has an 8-centimeter carcinoma. Which one? Right or left? Not a chance. And so you do this. You have one tissue defect and you have another one. And you go on and slice, and it's still black, and suddenly becomes white. Why? Because this must be a cyst with the through transmission. So as long as you slice here, it's black. Now it's white. So this is not important, but this one is important. That's a huge carcinoma. I didn't see the cyst. I didn't see the huge carcinoma. I still don't know where it is. Handheld ultrasound guided core biopsy, and MR shows very extensive cancer in the upper half of the breast. And if you look at the large section histology comparison, the whole upper half of the breast is full of cancer. And I didn't find it. Not fun. Not at all. I don't think we should continue with this. 8 centimeters. We have to do something about it. Now, the last one of the 3 dense breasts, BI-RADS 3, or BI-RADS C, and pattern 1. 72-year-old. I don't think anybody finds abnormality. This is an intramedullary lymph node. Not on the CC projections either. 2 years later, however, she develops a carcinoma. Where? Where most of the breast cancers are, in the upper outer quadrant. So I'm going to look at the lateral acquisition. Not immediately the AP or a medial. You find something else? It's very important. After having found one lesion, don't stop looking. Nope, I don't find anything else. So here it is. 5 by 2, about 10 millimeter deep to the skin. Yeah, right. When you compress it, it's about 10 millimeter. There you see the tissue defect, and then comes the handheld ultrasound, MR, one-shot core. We got a cancer. She developed a carcinoma. Are we done? Nope. She has another breast. Yeah, but the mammogram shows nothing. All right. What would you do? You would read the book taken as a lateral acquisition, and you find a cancer. It's not fair to treat her for the cancer in the right breast and let the cancer grow in the left breast. Is this a cancer? Yes, it is. This is in the right breast, and this is in the left breast. Benefit of ultrasound. Whether it is handheld, laborious, or automated. You see the carcinoma, about 10 millimeter. Now that's exactly when we should find the cancers. 9 by 8 millimeter, while the other one measured 14 millimeter. This 54-year-old woman felt a lump. Easy, you see it, palpate it, ultrasound-guided biopsy, fibroadenoma. Anything else? Here's the fibroadenoma. Nope, I don't see anything. Anybody can see anything here? Or 2 years later, the fibroadenoma starts to shrink. That's not an issue here. Mammogram still normal. Not very dense, pattern 1. But then the automated ultrasound finds tissue defects. 2. There is a satellite. There is a baby beside it. Look at this. This one and that one. Where was it? In the left breast. Left breast, AP acquisition. Let's go for handheld ultrasound, ultrasound-guided biopsy. MR, here is the larger one, and here is the satellite. Indeed, She has 2 cancers, and it was in the upper medial half of the breast. Here is the convex contoured lesion. You can compare, as you all of us should, with the 3D and the large section, thin section. Here is a carcinoma, and here is a baby beside it. Mammogram let you down. Automated breast ultrasound found it. MR found it. And we arrest the process. It was just about the time to do it because it's aggressive and fast growing. In addition, it also had DAB. That's why the small calcifications here. So actually, it's a very extensive disease. 23 millimeter, 6 millimeter, and a 6 centimeter cancer of ductal origin. I'm really moving toward the end of this webinar. Thanks very much for patience. But when this method was developed and we saw the potential, and I felt a déjà vu, back in the 1970s, when low-dose film screen mammography was worked out, science asked the question, so what? You move the time of diagnosis forward. You find it when it's non-palpable. Does it make a difference in outcome? And so here is this wonderful new method. As I showed you, hopefully convincingly, in many cases, we can find it when she already has it, but she doesn't feel it. So what, says science? So we simply had to repeat the story from the 70s. And it cost a fortune. My friend, Prof. Duffy, designed the study that goes down in history as SOMO Insight study. Published in Radiology. I'm just cutting very short. If and when we added automated breast ultrasound to full-field digital mammography, 26-27% more cancers were found. But then that was a multicentric, well-designed, perfectly carried out American study. The medical legal environment is different in America. So the callback rate was too high, questioning the acceptance of the method. So we ran another trial in Europe, and that's called the EASY study. In Europe, we have 2 to 3% callback rate. And imagine it only increased to 2.3%. And it found actually more cancers than the other trial. Now, this is why I'm saying, if we find 36% more cancers, if we add automated breast ultrasound to full-field digital mammography, then when we don't add this, then we are missing every third cancer. And that's not fair. So now we have a scientific evidence to the desire we always had. Let's have multi-modality approach screening. Then it's going to be fair to say the mammogram is needed for women with fatty replaced breast. And dear colleagues, this is exactly the story that should happen as soon as possible. She comes to the screening center, the technologist takes the full-field digital mammogram, fatty replaced. Thanks very much. Go home. Physician is going to read it, and you get a report. Now, what if it's pattern 1, 4, and 5? Then they take the mammogram, because ultrasound is not going to and should never replace mammography. Then before she goes home, you should have also automated breast ultrasound. And that's going to be about 40% of all women. And that was the structure of these two trials, and this shows good example for future clinical practice. And there is hope, namely, I don't think the CAD is very successful in reading mammograms, but there is a CAD, FDA approved, that helps the radiologist who don't need to page through all the pages of this children's book. You just pick up the book, and this CAD is called See Through. So you see immediately the tissue defect. Just imagine, you just read the mammograms, dense breast, and now you open the viewing station and there is a black hole. And then you say, great, I'm going to call this patient back. It may show small, it may show multiple lesions, whatever. I hope that you understand that we are very excited about implementing this scientifically proven method in mass screening in the future. I'd like to conclude with Dr. Connie Jones' brilliant statement. Yes, we can be very happy that we have a toolbox full with fantastic tools. And the well-trained radiologist knows exactly when to use one or another one, because, as Connie says, we have never been in a better position in the entire history of medicine to deliver life-saving breast imaging services with a tremendously high level of quality as we can today. Thank you very much for your attention.